Welcome to the Latte Lounge podcast. Join me, your host, Katie Taylor, as we talk balancing hormones, busting myths, breaking taboos, boosting libidos, and bolstering confidence. Why not grab a coffee or go for a walk and join us in the Latte Lounge as we chat all things midlife, menopause, and beyond. With thanks to our friends at Silk Natural Lubricant for making this podcast possible. In this episode, I'm going to be talking to menopause clinician, author and podcaster, Dr. Heather Hirsch, about the role of testosterone for women, especially in midlife. Often misunderstood as just a male hormone, testosterone can actually be the missing piece of the puzzle when it comes to our perimenopause and menopause symptoms. We'll be talking about what we need it for, how and why we lose it, how it can help with boosting libido, brain clarity, and energy levels too, but also why it may not be right for everyone. And we'll also find out why it's hard to get it prescribed in the UK right now. Dr. Hirsch is an internal medicine physician specialising in women's health and menopause care at the Brigham and Women's Hospital in Boston, USA. Her clinical work and research centres on inequalities or unanswered questions in the field of women's health, specifically in menopause education, and she aims to help women experiencing symptoms of perimenopause and menopause to thrive in midlife. Welcome, Heather. Thank you so much for joining me today.
Oh, I'm so excited I finally get to be here.
Now, listen, I thought we'd start off talking a little bit about our hormones. Now, most women obviously don't realise that as well as estrogen and progesterone, which we have talked about on our episodes before this one, we also have this third sex hormone, testosterone, don't we? So I just wondered if you could tell everyone a little bit about what the role of testosterone is in women and, where it's made and why we need it.
I think this question is such a great one. And I will start with there are some things about testosterone that we don't know. So I'm going to tell you what we do know, but what's really important is there's so much that we don't know, and there is immense value in what we don't know about testosterone. And here in the United States, we have the National Institute of Health. I always say to my patients, the NIH unfortunately isn't funding testosterone use in postmenopausal women or what testosterone's functionality and physiology is in women. And unfortunately, that is a huge gap. But testosterone is kind of the third of the cousins, right? Estrogen, progesterone, and testosterone. And we know that testosterone has significant roles in, one, the human species, because without it, we wouldn't get the urge to have sex. And without having sex, we wouldn't reproduce. And so it's very obvious that one of its main roles is in libido. In fact, testosterone spikes right before ovulation. So it's no coincidence. Most women will say, isn't testosterone a male hormone? And really, it's both men and women. It's just that men make 10 times more and they make it their entire lives. And women really only make it in a short amount of time. So we know it's good for libido. There's also some limited data to show that it's good for cognition. Now, certainly I could have people come for me to say there's not enough data and it's not strong enough and it's not powered enough. But look, there is some data to show that it helps with cognition. And again, we don't know what we don't know. Clinically, as a clinician, when I use testosterone, it does often help with brain fog or cognition. It might also help with bones. It might also help with vaginal dryness. It might also help with many other things that we kind of historically, I guess, think that estrogen does. Testosterone may also play a big role in.
I mean, where just so that we can sort of look at the anatomy, where is it made? I mean, obviously we know that estrogen's made in the ovaries. Is it the same?
So that's a great question. And, it's part of my question, so I should have answered that. But testosterone is made really in two places. It's made also in the ovaries. And this is important for women who have, let's say, early surgical menopause. Because if you have early surgical menopause, not only are you taking out all the estrogen, you're really taking out all the testosterone as well. It's one big reason that, particularly with patients who are younger than 45 and have surgical menopause, I do discuss with them testosterone replacement, even if they don't have low libido, because we know that the majority is made in the ovaries, but there's also some that's made in the adrenal glands, which are these little cute little organs that sit over your kidneys. And your adrenal glands make a lot of substances that are kind of wrapped up in corticoids or cortical or steroids, or cortisol or steroids. And testosterone looks a lot like steroids. They have the same sort of chemical structure. So there is a little bit also made in your adrenal glands. Now, if you don't mind me going off for a second, this is one reason why some women postmenopausally feel like they get facial hair, or they'll say, "Why do I have a beard?" It's actually because your brain is saying to your ovaries, like, Can you give us estrogen?" And your ovaries just lights are off. So they send an SOS message to your adrenal glands that sit above your kidneys. And your adrenal glands say, "Well, I don't have estrogen, but I have cortisol and I have testosterone. I've got a little bit of those and they look similar to estrogen. So here, I'll give you those." And that's one reason you can get facial hair and acne. Then sometimes if we're using hormone replacement therapy, not that everyone needs to do that or that's the only right answer, but if we use estrogen replacement, you'll see that facial hair go away. And it's because the body starts to feel less stress.
I love the way you describe that. I'm not sure I'm happy about that conversation going on, but let's see. Does the testosterone, so do our testosterone levels plummet, or sort of are they fluctuating like estrogen and progesterone? And you sort of touched on the impact that women perhaps can experience with these low levels. So it'd just be quite interesting to sort of understand how you would diagnose it, how women would know if they needed it, or and yeah, whether it's a sort of fluctuating thing, or whether it comes and goes and never comes back again.
Yeah, these are such good questions because, it's so hard to understand or have your doctor sometimes prescribe hormone replacement therapy that then kind of going back for the testosterone is like, seems like, you're just pushing the envelope so much. When unfortunately, these three hormones, estrogen, progesterone, testosterone, are really, wrapped up in each other. So the reference range for testosterone in some of my laboratories runs anywhere from about 5 to 50 on average. Let's just say 5 to 50, whereas men make about 200 to 400 or even 300 to 500. So you can see about 10 times more, right? Postmenopausally, I'll usually see women's testosterone levels close to that, like 5 or 10. Sometimes, however, if there's a lot of stress going on in the body, they'll be making fine amounts of testosterone. So the way a woman might wonder or know if she needs testosterone first, really, I know this sounds cheesy, but I think it really helps to bounce this off a good menopause expert because they can help you if you need it. I would say about a quarter or maybe at most a third of my patients are on testosterone. Certainly not all of them, but certainly not just a handful. Really, I tend to use the NAMS, which is the North American Menopause Society, the British Menopause Society, the International Menopause Society, the Endocrine Societies. They have a global consensus statement position paper on testosterone, which really the driving factor is low libido. So it's not weight gain or metabolism or brain fog, be it right or be it wrong. And low libido is typically one of the big driving factors for me to talk to my patients about testosterone. Then the next thing I do is I do check that lab value because if they're one of those women that is making testosterone because of stress, I certainly want to add to it. Wouldn't want to add to it because then they could get acne or start losing their hair, which is not going to feel good libido if they start losing their hair. So it really is a combination of symptomatology and lab work and really sort of seeing that testosterone is low. Now, you have to do a couple other things, make sure liver function tests and other things are good before you start testosterone and check those numbers frequently. I never want a patient to have super therapeutic or way too high levels of testosterone. That's just as important as replacing it, as making sure you're not overdoing it. I talk a lot about that on social media. And then the third thing is, you've got number one, symptoms, number two, low testosterone. And number three is, are you responding to it in an appropriate way? So if we start testosterone, my patient comes back and says, "Man, I don't think this is doing anything." We make sure the level is going up. If not, okay, we increase the dose a little bit. "I don't think this is doing anything." Then there's no reason to continue it if it's not having the symptom relief. So there's kind of those three guiding principles I have. Do you have, fundamentally low libido that's not improved with estrogen or with sleeping better or with therapy or something like that? Is your testosterone low? And are you getting benefit if we do replace it?
Yeah. And I want to come on in a minute to why, there might be other things going on. But how, as we're talking about testosterone now, how do you replace it for those who it's suitable for? And I guess also, are there any other ways to boost testosterone levels through any other ways, lifestyle tweaks like diet or exercise, or is it just part of a sort of hormone replacement therapy regime?
So this is a good question. Something that's been really popular lately is DHEA. DHEA in the United States, you can get over the counter at like a Whole Foods store. There is also DHEA that is intravaginal for genitourinary syndrome of menopause called Interocept. That's actually a prescription. But DHEA is a precursor to androgens, to testosterone. So some women will try to take oral DHEA. Although I will say clinically, it doesn't seem to do the trick like testosterone really does. Can you boost testosterone levels through exercise, particularly weight bearing, lifting weights and kind of that kind of thing? Maybe. How does it work? I'm not sure. Lifting weights is actually a stress on your body. So you could be releasing testosterone because of the stress response from weightlifting. Certainly, even things like for low libido that I always say to my patients could be helpful is reading erotica. There's neuronal connections in our brain about sex and fantasy, and even something as simple as reading erotica might not boost your testosterone per se, but your libido per se, if that's the main driving factor to start testosterone. And then how I use testosterone, there's two forms that I use primarily. The first is a topical route. So here in the United States, testosterone and probably actually most places, testosterone is not FDA approved. Testosterone is a controlled substance because God forbid women use testosterone. And mostly it's men that are abusing testosterone. I guess, I'm making big assumptions here. To kind of gain all that muscle and go to their strength competitions and things like that. Usually women don't want to overdose on it because it causes their hair to fall out and their voice to deepen. But here in the United States, in what the Endocrine Society really recommends is a low physiologic dose of topical testosterone. So physiologic means, remember when I was talking about reference ranges of testosterone are about 5 to 50. I really don't like my patients' testosterone to go too much above 50, maybe even 60. I mean, if we really need to, but you want to keep it in physiologic range. One of the things I don't do is testosterone injections. Specifically, they're called pellet injections here in the United States because I will see women's levels of testosterone be 100, 200, 250. Clearly, male levels of testosterone, although low levels, but still male levels. So I prefer a topical, low physiologic daily dose of testosterone. Keeps those levels really steady. So sometimes we use something called androgel and dose this for a female, or test stim and dose this for a female, or we just compound it. One other way I'll do it is there is an oral combination with conjugated equine estrogen and testosterone. This is called methyl testosterone, or the brand name is Coverix here in the United States. And I use that oral testosterone and that oral conjugated equine estrogen, particularly in, again, those younger women who have surgical menopause. They really physiologically need that testosterone. So I will sometimes, if they are okay with an oral or their past medical history allows that, I will give them an oral combination of that estrogen and testosterone together. I'm hopefully not talking too fast for your listeners.
Not at all. No, it's really, really helpful. And I want to come back in a minute to sort of how women do or don't, or I should say can and can't access it. But before I do, I know a lot of women are worried, oh my God, am I going to grow a beard, or am I going to have a deep voice and look like a man and be really muscly? So, I know you've touched on it a little bit, but are there any side effects, and sort of how often should we be monitored to make sure that we are absorbing it and that there aren't any sort of perhaps nasty side effects? And also, another question to add to that is, how long is it safe to stay on it for? Can it be forever, or is it just a temporary thing?
Great questions. So, how long to be on it for? That's another one that we don't really know. We don't have good data to show one way or the other. In my clinical practice, if women are on a low physiologic dose that they find helpful, just like their hormone therapy, I don't give them a time limit. But would I love more data or longer term studies on testosterone? Of course. Are they going to be impossible or nearly, you know, uh, just a work of magic to actually get funding for large academic centers to do that? Yes. So when it comes to side effects, I'm particularly what I tell my patients OCD about your testosterone levels. And really, what it comes down to is keeping those levels within a normal physiologic range for a woman. So I like to check their levels when they're first starting every 6 weeks, and then again another 6 weeks, and then every 6 months, and then maybe once a year. Once they're on a pretty standard dose, it's not really going to surprise you all that much. And I'll tell you what I tell my patients because I think that's the easiest way to say it. I'll say, okay, Katie, if we're starting testosterone, I promise the first side effect you will have if we're using a low physiologic dose of testosterone is a pimple or two. And if you see a pimple or two, we can do one of two things. We can go to every other day on your testosterone, or you can just kind of keep going and make sure it's not like a teenage pimple fest. If it is, that is the first clinical sign that your levels are getting too high. You're not going to have deepening of your voice or enlargement of your clitoris right away because a few pimples here and there is going to be the first signs that maybe your testosterone is becoming 60, 65, 70, 80. And if you were to have testosterone levels that were way too high for way too long, that's when all your hair would start to fall out, your voice would deepen, the clitoris could enlarge into a penis. And in reality, that's how we use hormone therapy for women, for folks who are transitioning. And that's not to scare you. That's really actually to make you feel comfortable that the first thing, if I'm doing testosterone with you in a safe way, that you would see is a pimple, you can handle that.
Yeah, absolutely. Although I wouldn't want too much back. I'm thinking about those horrible teenage years. So look,
Uh-huh.
we've talked a lot about the benefits of testosterone. Why is it so hard to get it licensed for use from doctors? Especially I don't know about the States, but here in the UK, many women, including myself, are often told by doctors. In fact, for me, it was my pharmacist. That it's not licensed, and they then mistake that as therefore it's illegal or unsafe, and B, they're not willing to
Mhm.
prescribe it either because they're not confident or their training is not up to date. And how can we try and get it if we feel we need it and we've done our research?
It's such a loaded and good question. And I will say that as hard as it is to replace the female hormones, estrogen and then progesterone, if you need it, because some women don't need it if they don't have a uterus, it's even harder to then kind of push for that third thing, which is the testosterone. And as much as sometimes it's easy on social media to put the blame on individual clinicians, in actuality, it really goes back to the medical education system. Whatever country we're in, it's all the same. Midlife and menopause and the declining of female hormones is not a priority in medical education. I once did this TikTok post. It was like 2 years ago where I was pretending to be a medical school teacher. And I said, okay, today we're learning the lesson on menopause. It's when your periods end. Class adjourned. The joke is that that is really as much education as they get. We really don't discuss how the loss of these hormones, estrogen, testosterone, and then possibly progesterone, interfere with chronic disease development, mood changes, metabolism shifts, and weight gain, sexual function, sexual health, which is health. motivation, even how these hormones interact with our brain, which is wrapped into mood, but other things like cognition, desire, so many fundamental parts of our lives. The average age of menopause is 51, 51 and a half, yet women are living a third of their lives, if not more. For many women, menopause is earlier than natural menopause. And the fact that we do not have good research, the fact that this has not been tied into something greater than, oh, you don't have to buy pads anymore, is a public health crisis. So it could be the lack of clinician knowledge, certainly, but instead of placing the blame on individual clinicians, we really should focus more systemically on why they haven't had good education on that, yet they know so much about asthma, COPD, childbirth, the risks of obesity and weight gain, is because that's what they have been given to know. That's what the colleges have decided collectively that's important. Until we get people to collectively decide that understanding midlife women's health with the loss of hormones is fundamentally important to overall health, we're stuck. And luckily we have social media where, your show and your podcast and your ability to bring women together and raise awareness outside of the medical schools and the medical community is what has been pushing this movement for the last probably 5 to 10 years. But, changing those red tape of medical education, especially when the demands of what to teach are going and going and going. We've got the opioid epidemic here in the United States. We've got, viruses. We've got all these new sorts of things. Climate change is probably being taught in medical school more than menopause. Not to say climate change is not important. It is. But they're all fighting for territory in parts of people's brains. Another way to do this is to really have people focus on certain things. And so another reason I love being on social media is I can encourage people to go into the field of women's health because it's so fun and it's so fascinating. It's just that we need the number of menopause doctors as we currently have cardiologists, which is not where we're at. It's not at all where we're at. You're asking me a lot of loaded questions this morning.
Well, look, like you, we're both really passionate about women's health and the lack of research for women's health and these sort of inequalities when it comes to this area of medicine or health and well-being. I mean, I'm delighted, especially here in the UK, that we've now got this women's health strategy. Menopause has been front and center. We've been campaigning now for and sort of bringing this to the forefront. Well, my own journey 7 years ago, and it's exhausting. But thankfully, there's a huge sort of uprising here in the UK and right across the globe. So the good thing is women are much more well informed. And as you say, we need, more education in schools, in medical schools, in workplaces. And this, I guess, that this lack of availability of testosterone is a really good example of these sort of inequalities. I mean, men would never never have put up with this. So look, but before I let you go, just sort of wondered if you could reflect on how these sort of inequalities sort of fit into some of the broader issues you see in terms of barriers women face, for access to the right treatment, obviously in the States, but here in the UK too.
Well, I think you really nailed it on the head here is that you are exhausted. You've been doing this for 7 years, probably out of your own story and passion and desire to educate other women. And I the same. And one of the things that is so frustrating is the low numbers of clinicians who are really knowledgeable in this area. One of the reasons there are not as many is it's not as lucrative of a career as let's just use cardiology because I already brought that up, right? And it's unfair that specialties that are focused significantly on cognitive decision making and shared decision making among patients get paid less because then you have also less folks who want to go into those fields. So not only do we have a mismatch in terms of medical education, but also in the United States, for example, you certainly can get paid a lot more if you do something seemingly much easier to me. Like, oh gosh, I don't want to put one of my colleagues on the spot, but you know, menopause is very difficult. It's emotionally difficult. But it's also lovely and satisfying, of course, because that's my job. So I know how wonderful of a job it is. I kind of say to each of my patients, each of you feels like a little Rubik's cube that I'm like moving and putting and learning all these clues and moving it all around to see, because there's just no one size that fits all. The other thing is that it takes a lot of experience to be a good menopause clinician. It's really hard to algorithm this. It's really hard to say everyone starts with this dose and this route and, this. It's really, really hard because women are complex. We don't know exactly how our bodies work in terms of how we metabolize certain drugs, what our proteomics are doing, what our metabolomics are doing. There's just so much that we don't know, which sounds kind of scary, but also it is fascinating to think that a lot of what we are doing is using clues. So, there's a lot of reasons that it's not equal between men and women. I always say men make sex hormones their whole lives and women's go up and down every month and then crash and burn.
It's true. And you can understand why so many marriages fall apart in midlife, because the male sort of sex drive may be going up or at least stabilizing, and women's are plummeting, and it can cause all sorts of problems in the marriage, and also women are leaving the workforce in their droves. I mean, I love your sort of analogy of the Rubik's cubes, and there's no one size fits all. When I look back over my own life, but then I'm sure so many women listening to this will relate to what I'm saying. We've been fed so much sort of misinformation about everything from nutrition to, what should I eat? What shouldn't I eat? Should I diet? Shouldn't I diet? This is bad for your health. This is good for your health. And so you kind of grew up in the sort of 80s as a teenager, pretty confused of how to look after yourself anyway. Then you have kids, and perhaps you might put on weight, or just sort of lose interest in your partners and your financial pressures. And then there's the menopause, and it's kind of no wonder that women are confused and not well looked after. And I think it's so important to find a clinician who'll look at you as a whole person and say, let's look at your health and lifestyle, let's look at your hormones, let's look at your family history, and also to remember that my last wish that I would say is that I wish all clinicians knew a lot more about menopause, because I was sent to a rheumatologist, a neurologist, a cardiologist, who actually knew very little about the fact that my heart palpitations, my aching joints, and my brain fog
All
actually,
had to do with one
yeah.
thing.
So can you imagine that? And I'm one person. So times that by hundreds of thousands of women, the amount of money, well, especially the NHS over here, would
Yep.
save. It's a no-brainer. So look, we could talk for hours about this, Heather, and I'm really happy that we've connected across the pond. And your knowledge is so valuable, and I really hope this podcast is going to help a lot of women listening. So, if they want to know more about you and want to follow you, where we'll obviously put everything in the show notes, but where can they find you after they've listened to this chat?
Yes. Well, you can find me on social media, all of them. I'm at Heather Hirsch, MD. That was a lot of work because I had different names for a while. I have a book coming out in the summer, June 6th, called Unlock Your Menopause Type, which is
Ah,
really cool because I talk about 6 different types of menopause. I actually talk about which types even seemingly do well with testosterone. So kind of tying that back to what we're talking about today. And although there's more than 6 different types, everyone's so individual. There's kind of 6 big themes sometimes I see as I've been seeing patients over the last 10 years. And I'd love to hear from you on social media. I get so many of my ideas for my own podcast, which is Health by Heather Hirsch, by y'all and my followers kind of writing me DMs or responding to stickers about what they're interested in. And so I'd love to have you join my community as well, because I do think there's so much we can learn both from truly how incredible of a job the UK has done in terms of advocacy and education and policy change, which even though it's so small, right, it seems not enough, it's still been a huge improvement compared to what we have in the United States. And I'm just so proud. I'm so proud of you. I'm so proud of all of the people. It really takes a village from clinicians to those who have masters in public health and statisticians and dietitians and laywomen and, policymakers, everyone. It takes a village to really bring this to where whatever meeting it needs to go to say, look, menopause needs to be on the menu and yesterday.
Absolutely. And you hit the nail on the head. I think all of us working together, we're certainly not going to go back into the dark ages. We're only going forward. And I think, for the next generation, they're going to hopefully have a much more positive experience. And Heather, I'm delighted to hear about your book, and I hope maybe we can chat again in June when the book's out. I'd love to chat
Yes.
more about the book, and I'll obviously be reading it because I'm sure I'll have more questions after that. So good
Oh,
luck with
great.
publication day.
Thank
Um,
you.
and thank you again for joining us.
Thank you. Thank you so much for all that you do. I really also am such a big fan and really so honored to be on your show and to be in front of your guests. And I hope to come back soon.
Oh, thank you, Heather. And thank you, everyone, for listening. Thanks so much for listening to the Latty Lounge podcast. If you've enjoyed this episode, it would mean a lot if you could subscribe wherever you're listening so you don't miss an episode. And finally, before I go, I just wanted to remind you to check out the episode show notes for all our extra resources. You'll find links in there for our free Facebook group and our free symptom checker, so you can track your own symptoms against a list of the 34 most common symptoms of perimenopause and menopause. See our show notes for more. This podcast was sponsored by Silk Natural Lubricant and produced by Emily Crosby Media.